The recording will be posted on the committee's webpage after the meeting. For everyone's reference, today's agenda can be found under the first tab in the meeting materials. As a reminder for everyone, please remember to use the healthcare cost transparency email box to send updates or questions. I will now turn it over to Chair Dr. Judy Zersenthal to call the meeting to order.
Thank you and welcome everyone. It's great to see you after a very long break. I hope you had a good year. A lot of things happened in the year. So it is now 2:05 and I call the August 28th meeting of the Advisory Committee on Primary Care to order. And thank you for joining. So today we will start with an overview of the agenda, which will begin with roll call. We'll vote to approve the meeting summary from last August meeting. Then we'll open the floor for public comment. After that, we are going to have a presentation from Jingping Xing, our Cost and Quality Analytics Manager here at HCA, who is going to provide an overview of primary care expenditure in Washington State. As you all know, the cost board is tasked with trying to increase primary care spend to 12%. And we are working on where we are from our new definition and then providing our expertise and insights on strategies to do so. Next, we're going to hear from Nico Jansen, who's the Senior Health Policy Analyst, and Rocky Patterson II, who's an actuary. They are both from the OIC on updates on Senate Bill 5084 that is relevant to our work. And then we are going to review the policies and strategies we developed last year to try and reach the 12% primary care expenditure target. So I'm going to review all the policies and their potential impacts and talk about current efforts and strategies underway, and then we can discuss any policy updates or modifications to the 7 recommendations, and then we will vote. One other announcement I wanted to make before we get into roll call: David Giuseppe has resigned from his position with the Healthcare Cost Transparency Board's data issues and the Primary Care Advisory Committees, as he had an exciting job change. So we'd like to thank him for his passion and commitment he brought to this work and wish him well in his new role. I will now begin the roll call, and I'm going to call on members by the first name in the order listed on the agenda, which is alphabetical by last name. When I call on you, please unmute your microphone and let us know that you're here, and then go on mute again. So, Crystal?
Here.
Sharon Brown? Tony?
Here.
Michelle?
Hi, good afternoon.
Tracy? DC? Sharon Eloranta? And she has recently retired, so she may also be moving off of this committee after a long and successful career and nice things to join us. Gregory? Chandra? Meg? I see that Cheryl's still on here, but she has actually moved to Nevada for also an exciting career opportunity. So I expect she will not be joining us. Lon?
Hello.
Hello. Katina?
Hi.
I saw you. Mandy? Jonathan?
Here.
Sarah? And Linda, I think, is also retired. I think it's Elizabeth that's maybe filled in. I don't know if
She's
here.
off. This is Riley. She is off the committee and being replaced Fitzgerald,
Yes.
who said she would be on 10 minutes late. So hopefully You guys
Okay.
will know how to sign her in list. So
We will keep an eye out for her and promote her to a panelist. Sean, Stacy, Ginny, and Maddie.
Hello.
I am here.
Oh,
Welcome.
excellent. Thanks, Ginny. Thanks, all of you. So with that, does anyone have any corrections on the minutes, or do they want to make a motion?
So moved.
Okay, we have a motion to approve the minutes from last year's meeting. A second?
I'll second.
Okay, all in favor say aye.
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 I
Any opposed? So the June meeting summary is approved. And now I'm going to turn it over to Rochelle for public comment.
Thank you, Judy. If a member of the public wishes to provide public comment, please raise your hand at this time. When you are called upon, please state your name and affiliation, if any, before speaking. Please do not raise your hand more than once. This ensures that everyone has a chance to speak. You are also welcome to provide comments in writing via email at any time. And please remember that this is the time for public comments, and questions and answer sessions during the meetings are times for committee members to ask questions. Let me check to see if there's any hands. Okay, it doesn't appear that there's anybody raising their hand for public comment. I'll just take one more quick scan, Judy. Okay, public comments closed. I'll go ahead and turn it back over to you for the next part of the agenda.
Unmute. I am super excited to welcome Jingping to help lead us through the primary care expenditure in Washington State based on our 2025 data call. So I'm passing it over to you, Jingping.
Thank you. Good afternoon, everyone. My name is Jingping. I'm the Cost and Quality Analytics Manager in the HCA's data team. Today, I'm going to present primary care expenditure in Washington State based on the Healthcare Cost Transparency Board's 2025 data call. Next. So today, I will first review the advisory committee's new primary care definition. Then we will look at the prime expenditure based on the 2025 data call for overall, by market, and by carrier. We'll conclude by limitations and conclusions. And last but not least, we'll save some time for questions. But feel free to stop me if you have any question during my presentation. So the 2025 data call collects calendar year 2020 and 2023 data, which will be added to our historical data set. One major change of the 2025 data call is the implementation of the new primary care definition. Our data call was launched in February. After months long of data resubmission and validation, we are now at the stage of conducting final data analytics. We have recently sent out carrier and provider reports. But we may still have to deal with data resubmission and validation after we receive feedbacks from carrier and providers. The final results will be presented at the public hearing in November. So all the results presented here today will be preliminary and are subject to change in the next few months. In the data call, at the state level, we collect total health expenditure by total medical expense, net cost of private health insurance, and CPHI, and other spending, such as health expenditures from VA, DOC, and LNI. The proportion of primary care expenditure was calculated relative to TME. That's the total medical expense. That's the aggregated health expenditure data reported by the carriers, which contains both claims and non-claim spending. Next slide, please. Under the new primary care definition, the primary care was identified by provider taxonomy code, procedure codes, and place of service code. So place of service code is something new in this new definition, but also we updated the provider taxonomy code and procedure codes. To be counted as a primary care, the specific service has to be provided by a primary care provider in a primary care setting, such as outpatient office and FQHC. Next, please. This new definition also has non-claim-based definition, which includes payments for like capitation, physician salaries, incentive payments, population health payments, and practice support payments. However, in the 2025 data call, we haven't collected non-claim-based primary care expenditure. Next, please. Our old definition, which is based on only provider taxonomy code and the procedure codes, were applied to our historical data, which was based on the narrow definition outlined in the OFM's primary care expenditure report. Next slide. Let's look at the results. So here, the green line is for historic data, which was based on the old definition, and the blue line is for calendar year 2022 and the 2023 data, which was based on the new definition. Calendar year 2022 data was collected twice because last year we were collecting 21 and 22 data, which was based on old definition, and this year we were collecting 22 and 23 data, which was based on the new definition. The per capita primary care spending in Washington State is between $200 to $300 per year. And like many other services, the primary care expenditure decreased when the pandemic hit, and it rebounded very quickly in the post-pandemic period. In 2023, primary care accounts for 3.6% of total medical expense. And if we look at the graph on the right side, like the proportion of primary expenditure has stagnated in the post-pandemic period. The implementation of the new primary care definition has yielded a lower per capita primary care expenditure and also a lower proportion of primary expenditure because the new definition is stricter compared with old definition. Next slide, please. Looking at the primary expenditure by market, here we have like Medicare managed care. Medicare is only for Medicare managed care, excluding Medicare fee for service, because Medicare, because CMS, they didn't separately report physician primary care expenditure. The primary care per capita primary care spending was the highest for Medicare managed care population, followed by commercial and Medicaid. However, the proportion of primary care expenditure was the highest for Medicaid population, which was 4.1% in 2023, and the lowest for Medicare managed care population, because the elderly population usually has higher expenditures for inpatient and outpatient services, but also the prescription drug expenditures. Next slide. Here, the primary expenditure also vary by carriers. In the 2022, the median proportional primary expenditure was 3.4% across 14 carriers. And the values are not spread out widely compared with the old definition. Next slide. This slide shows the primary care expenditure in other states implementing the cost growth program. Because every state has its own definition of primary care, so here the range is wide. because Washington's primary care definition was relatively narrow or stricter. So the proportion of primary expenditure is the lowest among the 3 states who have reported primary expenditure for overall market and by market. Next slide. This slide shows primary expenditure based on the National Academy of Science, Engineering, and Medicine's narrow definition. Here we are comparing apples to apples because it's based on the same definition. However, like the definition is still like very different from our primary care new definition. But it shows that consistent with the data core results, it shows that the Medicare population has the lowest proportion of primary care expenditure, and the Medicaid has the highest proportion of primary care expenditure. Next slide. Our study has some limitations. First, we didn't collect non-claim based primary care expenditure. And we only have calendar year 2022 and 2023 data, so there is not enough data points to establish a clear trend line for primary care based on the new definition. And another limitation is that the Medicare fee-for-service is excluded because CMS didn't report primary care physician spending for this category. They aggregated it to a physician category, but not like reported separately for primary care physician. Next slide. To accurately calculate primary expenditure, we need to collect non-claim based primary expenditure in our next data core. And because the primary expenditure in Washington State is only 3.6% in 2023, this is much lower than the 12% target established by the Senate Bill 5589. I think that's the last slide. Any questions? This slide shows this is just for your reference, shows the difference between new definition and the old definition based on the provided taxonomy code. Crystal has a question.
Yeah, if I'm recalling correctly, and bear with me, it's been a little bit, when we did set the definition, we were looking at some other states that had similar, narrow definitions as well. So I just want to make sure I understand what you're saying is when we compare ourselves to the other state, you're still feeling like it's potentially not apples to apples.
Yeah, a lot of the definitions are based on the provided taxonomy code and procedure codes. Our definition, to be counted as a primary care, it has to this claim has to is for specific procedure by primary care provider, and most important is that it has to be in a primary care setting. So the service has to be for an office visit, or for an FQHC, or in a rural health clinic. So it's very strict compared with other states' definition of primary care. So they are not exactly the same, although they all define the primary care.
So we feel like there's not another state we can really benchmark against, is what you're saying?
Yeah, based on the data code, no, we cannot.
Gotcha. Thanks for the clarification.
Any other questions or comments? Yes.
Hi, this is Lan. I was looking at your comparison with other states, and this is based on 2022 data. Is there a desire maybe to compare based on 2023 or more updated data as well, just taking into account COVID and how things may have changed as we look at those years?
Are you talking about like the slides comparing other states based on the same definition?
Yes.
That one is based on the Milbank's primary care report, which was updated until like 2022. But we can keep an eye on their most recent, but the 2022 seems the most recent one.
Yeah, it's definitely tricky because one, the data is a little old, but two, we're changing our definition, and other states that are doing this are doing that as well. So there'll be some settling out, I think. Okay, well, thank you so much, Jingping. And yes, I am looking forward to next year and seeing sort of how this evolves. Hopefully we are making progress. Next, I'd like to welcome Nico and Rocky, who are from the Office of the Insurance Commissioner, to give us an overview on Senate Bill 5084.
Hello, can everyone see me and hear me all right?
Yes.
Okay, great. Thank you so much, Judy. Since we were scheduled to start at 3, I've sent Rocky a message and he let me know he's going to be joining in the next 10 minutes. So I'm going to do my presentation portion, which should be about that long, and then turn it over to Rocky. So he'll be joining us and we'll join soon.
Perfect. Thanks.
So, can you go back to the last slide for a second? So again, I'm a health policy analyst with the Office of the Insurance Commissioner, and I'll be joined today by one of our actuaries. And we're here to give you some information on a legislative update that's relevant to the OIC's collection of primary care spending information, and as it relates to our collaboration with the Healthcare Authority to do that. Okay, you can go to the next slide. So SB 5084, which some of you have probably heard of or tracked, was considered in the legislature this year. It was enacted. It became effective July 27th of 2025, which was 3 months after the enactment date. So current law before this bill passed said that we had the authority to assess primary care spending information from health carriers, that is, health insurers. However, we could only do that from the rate and form filings that health insurers submit. And the OIC realized over the last few years that this approach was not feasible in practice. That's because we receive hundreds of different rate and form filings from health insurers, so it proved an impractical method. So we worked with the legislature on this technical change to the law, and SB 5084 now authorizes the OIC to require health carriers to annually report primary care expenditures for previous or upcoming calendar years. And you can scroll to the next slide. So further, the Act directs us to consider this advisory committee's primary care definition, which I know Jingping just talked about, and also consider the Healthcare Authority's existing methods for collecting primary care spending information for the Medicaid program and for PEB and SEB. In addition, the legislation requires that the primary care spending information that insurers are providing is public information. And last, current law, which wasn't amended in this bill, allows the OIC to determine what's called the form and content of this reporting. So it gives us some discretion in determining how we'll collect the information essentially. Okay, you can go to the next slide. So in working on this legislation this session, I think one of the issues we communicated to the legislature is that where we can, if possible, we want to be working together across state agencies like the OIC and the HCA and have as much consistency as we can. So in this case, the OIC regulates fully insured commercial health plans. So the individual market sold on the health benefit exchange, the small group market, so small businesses, and then the fully insured portion of the large group market, right? Whereas HCA has been collecting this information for Medicaid and PEB and SEB. So I think the idea here is that we can align how we're working together to track this information where it's possible and where it's feasible so that it's consistent. And together, Medicaid, PEB and SEB, and the portion of the market that the OIC regulates represents close to half of coverage for Washingtonians. I think it's about 45%, and that's according to the enrollment data that we track. And then I think another goal of this in the conversations with the legislature is that in order to work towards the 12% spending goal that Jingping was talking about, it's important to have accurate measurement. And so we think that the consistency across agencies can help advance that accurate measurement towards reaching those goals. You can go to the next slide. So we're working on implementing this law and this new authority that it gives us, and we're working with the Healthcare Authority team to do that, including some of you, or many of you, I should say, that are on the call today. The OIC plans to include this primary care spending data into what we call annual financial statements that the health insurers we regulate are already submitting to the OIC. And specifically, we require health insurers that are domiciled in Washington State to provide us with annual financial statements. They have really detailed information in terms of that insurer's business and its markets, right? And so we believe that this is an efficient way to collect this information because it's an existing reporting requirement that they have. We're also working on enhancements to the template that the Healthcare Authority, as I understand it, has been using to collect primary care spending information. And I think our overall goal in that collaboration is to have a streamlined and consistent approach that collects information across these various markets and programs, kind of as I said before. Okay, you can go to the next slide. For this slide, I'm going to check if my colleague Rocky is able to join. I'm just looking down the list here, and maybe Rochelle or Judy, you can help me see if he's joined or joined the waiting room.
Let me check for you.
Okay.
It doesn't look like he's on yet.
I'm happy to go through these next few slides. I'll just caveat it and
Or
say that
maybe if people have questions, we could start if people have any questions about that part of it.
oh, Judy, that's a great suggestion. Yep. We can pause to give Rocky a little bit more time through that. Any questions on what I've covered so far?
Hi, this is Michelle Crosley. Are we talking about having kind of two different reporting paths? Because we're also capturing claims, carriers are also submitting claims-based data, which is probably soon going to also include claims payment, but then there's also going to be this reporting to the OIC. Is that how I'm understanding it correctly? It'll be a secondary reporting of primary care?
I'll let Judy and others from the HCA speak to this as well, but we're actively having conversations with the HCA and working on this. And I think we're determining how the reporting paths are going to work. And I think that there is a general goal of trying to make it consistent and not duplicative. Yeah,
Yes.
Judy or
I will
others, do you want
agree
to add
with
to that?
that. Yes, because I think it's really great that OIC is going to be able to do this, and I think it'll be a more robust measurement potentially than what we've been able to do. And so the goal is to make it a single streamlined place, recognizing that some data will be coming from us on this. So it'll be a little bit of a both, but our goal is to make it a single entry point for plans reporting.
Okay. Okay. Yeah, I just have a lot of concerns because if we're talking, and maybe they're both, and maybe we're submitting claims data on both sides, and that I guess is okay. But if we're having carriers roll up all the information on this OIC template and then submitting raw claims data information to HCA, who then is doing their calculations, I can just see a lot of, misdirection in terms of the reporting. So
Yes.
but
We
obviously
need
you guys are
to.
thinking about that. So.
And that's why we're trying to figure it out so that there is some data that we have that OIC doesn't have. And so we're trying to sort that out. But yes, I think ideally we would not be sending the same thing both places. So it's still TBD, but that is our goal, to not have OIC and us have different
Different measurements.
primary care
Yeah.
spends done. So
Okay. Thank you.
Yeah, appreciate the concern, Michelle, and that's definitely something we're working on. So I see Rocky has joined. Rocky, I'm sorry to take you out of what your earlier work was, but thanks for joining. Actually, we're at the segue where we were going to start talking about the enhancements to the template that you're working on.
Okay.
So
All right.
I haven't covered them yet, so I think you can start from the beginning, really, of this slide and this portion.
Okay, that sounds good. Thanks. Hi, I'm Rocky Patterson. I'm an actuary here at the OIC, working on revisions to the template and enhancements and trying to reconcile and match it up with statutory accounting. So essentially, starting off with capturing claims and non-claims expenditures, we revised that those labels a bit to reflect the statutory accounting language, where it'll be essentially benefits or non-benefits expenditures. That kind of aligns with that financial reporting language. Additionally, we added a jurisdiction rules section, or allocation by jurisdiction rules section, that essentially comes from the financial statement instructions. And this is a change where previously what was allocated was based on location of where services were provided, and under the annual statements instructions, it essentially changes that based on residence, essentially, and the same jurisdiction rules that are applied to financial statements and financial reporting. So, for instance, under the change, someone who is a Washington resident that receives care out of network in, say, Oregon or Idaho, or maybe they're a snowbird in Arizona, their claims would be captured under these rules. So the next component here, so we revise some of the calculation of what I'm calling the performance metric, essentially the primary care spend over all spending to somewhat align more with like medical loss ratio theory, where the denominator essentially captures all spending required to provide healthcare, and the numerator will require be defined as primary care benefit spending and primary care investments and support expenditures. And next slide, please. So we also added some additional supplemental data elements that would be helpful for understanding why things are changing, and to essentially, well, one of the key things is, for instance, adding member months. That allows us to understand whether spending is scaling because of size of the pool or the members covered versus, increasing or decreasing, and how that could impact overall totals, as well as allocating spending from primary care to facility fees, urgent care, and hospital, be it on campus or off campus. The idea here is, in theory, you could report primary care spending and show that it's increasing, but not actually be either increasing the utilization of primary care spending or keeping primary care utilization the same, but just shifting to more expensive primary care services or locations. So this is to understand and measure that, essentially. So some of the language and details in the individual elements and how they're broken out were not significantly changed, but just tweaked a little bit in their headings and how they were categorized in our template to match statutory accounting, like I said, the jurisdiction rules, how they're referenced in annual statement instructions and statutory accounting. We had some alignment changes there, but it's really more of labeling than it is significant differences in the numbers. I don't expect there to be a significant difference in the numbers, other than that jurisdiction rules. That's a significant change. Let's see. So we also worked with HCA to determine what carriers they need to report, so we could eventually all use the same template, or maybe even report in one location. We also looked at market share and essentially created a list of carriers to capture the highest market share carriers and asked them to report using this template. So there's a section that names the carriers that we're asking to report. Let's see, next slide.
Did you want me to cover this part, Rocky? Would you like to?
Should we go over questions of the previous, or should we just go through and then do questions at the end?
Sure. Let's open it up for any questions on the template.
And I can actually show it if that would be helpful.
I'd like to see the template if you have it.
Sure. Okay, can you see that?
Yes.
Yep.
Okay. Yeah, so it looks quite a bit different. It's consolidated, so all the data entry is on one sheet, and all of the lines of business are on one sheet. You can see here there's company name, reporting, reporting periods, the lines of business total. This first section essentially captures the key metrics that we're looking at or that we're interested in. And then below yellow cells is where carriers will enter data. And it's broken out by healthcare expenditures. This is overall, and then primary care data, which is subcategorized into benefit payments, support and investment payments, and then supplemental data elements. Sorry if I went too fast there. I know you get dizzy when someone else is scrolling.
When it comes to meeting the 12% benchmark, is it the OIC or the HCA that is determining that calculation? I have a lot of alarm bells going off, sorry. And just to be transparent, I represent United Healthcare, but you know, so in this template, we're asking the carriers to roll up all the information, you know, according to the definitions that they're provided. But
Yeah.
then on the HCA side, we're just giving claims-based, more detailed minutia that the HCA can then, you know, roll up and define. And I'm just really concerned that
The level of detail isn't different.
okay.
As far as what this template is based on HCA's template, it's just reformatted, and the definitions and instructions that we put together make sure that it aligns with financial reporting, and because it is essentially considered a financial report, just like the annual statement or additional data statement that your company submits quarterly with our office. The 12% target, just to remind you, doesn't have any financial incentive or penalty right now. This is just informational. So regarding, you know,
I guess I'm still confused, like why the dual reporting requirement?
well, we regulate the market at OIC, and HCA regulates state-based coverage. That is my understanding, and not also they have self-funded and Medicaid business there. I believe that we've talked about possibly trying to have one area, one path of reporting, and this is the first step where we're exploring that. We're definitely not there yet. Does anyone else want to add on to that?
Well, Michelle, I would add to that that as the commercial insurance regulator in Washington, the legislature has directed us to do this. And we're working with the HCA toward making that, like I said, as consistent as possible, avoid duplication, but we're fulfilling a statutory mandate.
This is Jane Beyer from OIC. My understanding is that the goal of all this is to not have duplicate reporting. And I think Michelle Judy tried to explain that in a response to your earlier question. What we're trying to do here is integrate collection of primary care data into the work that carriers do every year in developing their annual financial statements. So help me understand why you think it's as duplicate reporting.
Yes, and then I'll say that HCA is trying to get out of that business for the primary care spend of what we're doing. And so we think it actually helps us to have OIC doing this.
Okay, thank you for the explanation.
Also, OIC didn't, they don't regulate Medicare. So, in our data core, we collect the data from all carriers, including Medicare, managed care. So that's the one part that will be missing from OIC's data collection.
And the self-funded, yeah. So there would be, we have added Medicare Advantage and Apple Health columns here. So those lines would be captured in this template. Of course, this isn't final yet, but it's very close to being final.
Crystal, did you have a question?
Yeah, I just want to make sure I'm tracking. So you're saying there are some payers that wouldn't be included here. It looked like the Medicare Advantage wouldn't be included except for PEB.
Right.
Only PEB, yeah.
So that's I'm a provider. That's a lot of our patients are the Medicare Advantage. Is there the hope that they're going to continue to use a different format, or that this would then be deployed to capture that spend? Or will there be two different reports because of that?
Jane?
Yeah, I think that's a really good question. Let us work with the Healthcare Authority on that. Under federal law, I mean, if the Healthcare Authority authorizes us to collect it for the PEB Medicare Advantage plan, that's one thing, right? Because HCA sponsors that PEB Medicare Advantage plan. And if Jingping is still on, Jingping, in the reporting that we're doing now, are you getting all Medicare Advantage data that the carriers are voluntarily sharing?
Yes.
Okay, so let us take that question under advisement in terms of how we can try to figure out how to capture that information.
Right, because it's also not just that line. It would also be, are the carriers different, right? That we list as far as
Right.
who needs to report. So it's not as simple as just adding it, but yeah, it's complicated.
We'll work on that though.
It's a good question.
Yep.
It is for sure complicated.
Yeah, there's been a lot of hours
A lot of conversation
poured into this.
Yeah.
Actually, one other thing that I mentioned I forgot to mention when I was going through the slides, is that we discussed adding a supplemental data metric that captures preventative services, how much of primary care is considered preventative. And it's something that we're interested in adding in the future. We didn't add it this year because we found that defining preventative services was very complicated. So we'll see how that goes maybe next year.
So we can take any more questions people had on the template, and then otherwise we can cover some of the planned dates or time periods for our next steps. did anybody have any other questions on the template for Rocky? Okay. Did you want to, was Rochelle or who's managing the slides, did you want to go to back to the presentation and I think it was the next step slide?
Yes, let us pull it up. Just 1 second.
No worries, thanks. So I can cover this and Rocky and Jane can add anything that they would like. So at this point, we feel the first plan year we can capture these data for is plan year 2025. So that's going to be the first year. What we plan on doing is sending instructions to the carriers this fall as part of the instructions for the annual financial statements. And then those reports would be due from the carriers by July of 2026, and that would capture plan year 2025. And then lastly, as we work on this in the coming years and consider any other refinements to the template or the, working with HCA, working with this advisory group, it's possible we'll adjust the instructions in those future years as well. Rocky or Jane, do you want to add anything on this slide?
Nope.
Nope. That's it. Thanks.
Okay. And then the next slide just has my contact information. Happy to be a point of contact for the OIC on this work. So we can open it up to any further questions on any of our presentation right now before moving on to Judy, what you have next on your agenda.
Great. Any other questions? Thank you, Nico and Rocky and Jane, for joining us today. I'm very excited. This is going to sort of streamline and sort of organize the data, and this will be very exciting. So I appreciate your collaboration with us.
Happy to help.
Thanks.
So next, I'm going to move through the 7 policies and strategies that we had approved and recommended to the cost board last year. So it's time to do that again. And so I'm going to start with a little bit of background, and then we can sort through whether we want to make any changes or not. So as you all may remember, but it's been a while since we've been together, in 2022, the legislature directed the Healthcare Cost Transparency Board to define and measure primary care spending and to develop recommendations on how to achieve Washington's target of 12% primary care spend of total healthcare expenditures. And next slide. Why 12%? Again, I think I'm probably preaching to the choir, but primary care is a fundamental and essential part of the healthcare system and provides folks an entry point into the healthcare system, and everything from prevention to chronic disease management to acute care needs. And there's a great deal of research that shows access to primary care is associated with better health outcomes, increased equity, and higher life expectancy, and also results in lower healthcare costs by decreasing hospitalization and some ER rates. Next slide. Over time, and I think as many as you live this, expectations related to primary care service delivery has increased, while practitioners remain understaffed and underpaid compared to other medical specialties, which has led to a number of issues we have talked about here in the past, including primary care delivery, workforce issues, and limited access to care. And there is strong evidence that supports the value of investing in primary care to get to those better health outcomes and lower total healthcare costs. Next. So as you may remember, we have 4 key areas that are used to evaluate our primary care expenditures. And we looked at all of these when developing our 7 strategies last year. To go around the circle, I'll start with direct investment, which is paying more for primary care services. Second is capacity growth, which means reducing barriers so that time can be spent on patient care and patient services, and also workforce investment. Third is patient behavior, so making sure that folks know that primary care services are available and a great place to go, and understanding the role of primary care in the larger healthcare system. And then finally, reduced expenditures on other services because there is greater primary care access. Next slide. So these were the principles we used when developing the 7 strategies. The strategies that we recommend to the cost board should closely link to the 12% primary care expenditure target. They should have clearly defined action and actors, be financially, operationally, and politically feasible, and improve access and quality, not just improve expenditure. So next slide. These are the 7 policies. And I think I will go through them one at a time. And after I share where we are, then I'll pause a little bit to see if people want to add anything about how things might be changed, or if anything is different, and then we'll continue on. So the first one, and oh, I guess next slide, there's one more. I'll review the summary, and we will discuss and vote any policy modifications we might want to make. And then at the end, we'll vote on final language for each recommendation, and that vote will go to the cost board, who will then vote on it, and it will go to the in their report of recommendations to the legislature. So now, recommendation number 1. So recommendation number 1 was that the legislature should codify a goal to increase primary care spending by 2 percentage points per year. The committee decided that because we felt like we were behind and needed to accelerate and focus on this effort. Oh, go back, please. We made recommendations that the legislature should require HCA, the Health Benefit Exchange, and the Office of the Insurance Commissioner, who you just heard from, publicly report primary care expenditure ratios, and then recommend that OIC submit a report to the legislature proposing how payers will be held accountable for this. Next slide. So this recommendation is important because small increases in primary care spend require a fair bit of increase in primary care reimbursement if you are holding utilization and total expenditures constant. And total expenditures include a lot of moving pieces. And so ideally, increasing primary care reimbursement would increase the use of primary care services, and increasing that primary care access would decrease the utilization of other service categories, most notably avoidable emergency room visits and inpatient care that's avoidable. It is all very interrelated, but sort of the first step in this process. So next slide. So last year, after we made this recommendation, the cost board changed that recommendation to 1% increase per year. The rationale for that was that the folks on the cost board felt like 2% was too ambitious, and to start with 1% and see how that went, and then an increase from there. The legislature did not take this up, but they did pass Senate Bill 5084, which you just heard about, that directs OIC to collect primary care spend information, and that I think is a nice step forward in this work. So I'm going to pause there and see if there are any questions or comments about that. Maddie, you're a little garbled. You might be in a place that doesn't have great cell service, because it's very garbly and
Okay.
mechanical. Oh, now you're better.
My chat. Oh, can you hear me?
Yes.
That's what's been happening. If we're going to decrease to 1%, are they really going to look at it in 1 year? Is that going to be built in? Because part of why we chose 2% is we felt 1% was going to take too long. Yes. And primary care was going to suffer. So,
yeah. I think that we could either decide to keep our recommendation at 2% or we could change it to 1%. Yeah.
Okay. Well, my recommendation would be to keep it at 2%. So.
Okay. What do other folks think about that?
So I just want to ask, the data that we reviewed earlier showing where we were currently at as a state, that did not include the non-claims payment, correct?
It did not, yes.
Okay, so that's why I feel like we don't really know where we're at. Like if we're comparing ourselves, for example, to Oregon, which does use non-claims payment in their reporting, so their percentage looks much higher. I feel like we don't really know where we're truly at without that piece. So it's hard for me to go to the 2% because we really don't know how far below the 12% we are. But I'm assuming we want to include non-claims incentive payments, whatnot, towards the 12%, correct?
Yes, that is in our definition. And there were sort of a variety of reasons that we didn't end up being able to get that this year. And so you are correct. We don't have the non-claims based payment. And I think that has been increasing in terms of quality incentives, care coordination, sort of alternative payment models. That's been increasing as a part of primary care reimbursement. So there is probably a chunk that we're not getting.
Yeah. So, I mean, for that reason, I would probably keep the recommendation from the cost board of 1% would be my vote.
Lan?
Yeah, I agree, Michelle. And then with the OIC asking for 2025 data too in the fall, I think that would give us a better picture of what it looks like with newer data for current state in Washington.
Yes, I'd hoped that we would have a magic number that we could start benchmarking from, but we're just not quite there this year. So do other folks have comments or questions about this? Okay, I'll move on to number 2, recommendation number 2. And so this was to increase Medicaid reimbursement, that the legislature should increase Medicaid reimbursement for primary care services to no less than Medicare rates by 2026. And they should direct HCA to implement the increase by using the enhanced adult primary care and enhanced pediatric fee schedules. And that any payment rate that wasn't already at or above Medicare should be kept the same, and then others increased. And that the fee schedule increase should happen no later than 2026. Next slide. This is important because there is likely a connection between higher reimbursement and better access, and a connection between higher reimbursement and an increased ratio of primary care expenditures to total health care costs, and that this will likely lead to additional positive effects for both equity and for workforce stability. Next slide. And this is the bummer part that you all know. Last legislative session, we did not have a lot of funding, and we have a state funding gap that we are continuing to experience. In addition to that, there have been a lot of federal changes, and there is likely going to be a decrease in federal spending on Medicaid and impacts to our budget. So there is currently not any effort underway to increase Medicaid rates at this time. Do people have comments or changes or edits they think would be helpful for this one? Okay, this is the bummer one for sure. Yes, and I'm hopeful that things will eventually change and we can work on this one again. Next slide. So recommendation 3 is multi-payer alignment, and the committee endorsed the multi-payer collaboratives work in aligning standards, quality metrics, practice supports, and payment models. And they also endorsed the collaborative efforts to align with the federal Making Care Primary program, and wanted the legislature to advance multi-payer primary care alignment efforts, particularly for state-funded plans to help them participate in Making Care Primary. Next slide. That is all important because it'll drive momentum towards a common direction with shared goals and best practices, and reduce avoidable utilization and cost, and reduce administrative burden for providers and payers by doing this. And it will be helpful to providers because there will be more than one payer's portion of patient population. There is more than one payer's portion of a patient population served in primary care. And so aligning the direction makes it easier for primary care to make advances. Next slide. This is some more things that you know, but the multi-payer collaborative work plan for this year includes attribution alignment, some common communication with providers and purchasers, and identifying plan alignment opportunities to support value-based purchasing. We have, and we are underway in all those areas. We soft launched a couple of months ago and now have launched more publicly the primary care recognition program that will allow us to understand where practices are in their primary care journey from level 1, that is sort of just starting things, to level 3, which is advanced primary care practice. We had a number of practices, somewhere in the 8 to 10 range, from the Greater Health Now ACH pilot, this recognition program. And it was very exciting to me that they found that over the course of about a year and a half, with someone engaging with their practice, all of those practices not only were able to measure where they were in recognition, but move up at least one level. There was one practice that moved up 2 levels over that year and a half time frame, which was very exciting to me to prove that this could work. Other things that HCA is up to is that we are continuing to convene a quarterly purchaser group to help employers figure out through their contracting how they can support primary care and support this effort. And then I think, as you all know, Making Care Primary was canceled by this administration in March. We have all committed, and the Multi-Payer Collaborative has committed to continuing this work without Medicare. I think having Medicare would have added some extra oomph to our efforts, but I think it's also fine for us to keep going. I want to call out next the Washington Health Benefit Exchange. In their most recent contracts that went live July 1st of 2025, is that any insurers that are on the marketplace have to participate in the Multi-Payer Collaborative and sign the Memorandum of Understanding. And then the last thing that's happened in this space is that during the last legislative session, there was a legislative proviso to create a provider forum. So we have the multi-payer collaborative going. We have this purchaser collaborative. The one space that's missing is where the primary care providers. We are on track to have a first meeting of that group by the end of September, and we are very close to identifying some initial folks to be on that provider forum. So I'm going to pause there because this one is probably the most active. Do people have questions or comments about any of this, things they might want to change? Crystal?
Nice. Yeah, Crystal again. I'm more curious what that interplay looks like between that new primary care group and the work that we're doing, just thinking about alignment, kind of moving everyone in the same direction, and that visibility between the different bodies of work.
Yeah.
Is there more to come on that?
So it's a great question, and actually the things that they're supposed to do are different. So this committee is supposed to work towards primary care spend by defining, which we did, and then measuring every year and making recommendations to change it. The provider forum has 2 objectives. One is to interact with the multi-payer collaborative to give some interplay about what practices are struggling with in their general operations and in making this model. I think they're designed to have some examples, I would say, of where things are working and not working so well. And then they are also charged with working with the multi-payer collaborative to increase the uptake of value-based purchasing models for primary care, which is part of the goal of the Primary Care Transformation Initiative. So aligned, but slightly different.
Yeah, very helpful.
Okay, next. So recommendation number 4 was patient engagement, and the committee endorses HCA's efforts to participate in Making Care Primary and the Primary care transformation initiative, especially to pursue resources for primary care practices to better provide whole person care, and also to support any state agency's efforts to have incentives for members to access primary care services. Next slide. This is important because everyone has a role in patient engagement, employers, insurance carriers, primary care providers, and patients. And by encouraging folks to participate in their own care, there's a better chance for people to be able to understand their own health and their chronic disease and their prevention. And patient engagement plays a critical role in helping improve health outcomes and contributing to achieving the state's 12% target when employers encourage the use of primary care services. Next slide. So for this one, there are currently no efforts underway. We had been doing some shared decision making. Some of that is on pause for now, but I think this still remains an important area that we need to make some progress in. Do other folks have questions, comments, changes to this one? Okay, number 5. So number 5 was that the committee endorses the Health Workforce Council recommendations that would increase access to primary care services. And next slide. This is important because workforce shortages create a lack of access to primary care and contribute to burnout, not only among primary care, but also other health providers. Washington has fewer physicians per capita, including primary care physicians, compared to the rest of the US. Only 35% of Washington physicians, and this is the, I apologize for the nurse practitioners and the PAs that this is the data we have, but only 35% of physicians work in primary care, provide direct patient care, are not federally employed, and are under the age of 75. And so patients lack access to care in primary care because there are shortages, and then they go to the ER and potentially even get admitted to the hospital for care. Behavioral health workforce shortages also make it rough on primary care and make it rough on the patients with behavioral health conditions, to make sure that people can get their behavioral health needs met. And then shortages at long-term care facilities lead to discharge issues at hospitals. Next slide. So there has been some progress on this from the Workforce Council, and one piece of that is an overarching rural workforce goal that is new. I think there is also potential in this rural area. The federal administration, as part of House Bill 1, OB3, had a grant opportunity for states to improve rural health care. And so I think both of those things are on the docket. The federal government has not released what that rural grant will look like. So I hope that all of you have seen emails asking for input on what you think is important for us to address with that rural health goal. But those are the two things happening in rural health. They also have a recommendation on community resources, so thinking about childcare, housing, and transportation and how that impacts workforces, and then educational debt. This year, our workforce unit contracted to award 331 students across 9 Washington community and technical colleges to pay for some of their expenses as they pursued a career in the health workforce. And that full impact is is coming soon. So questions or comments on this? Okay, next slide. Oh, and I forgot about this. There's ongoing work of the Sentinel network, collecting data and looking at employer recruitment targets and what they are for behavioral health, oral health, and rural providers, and how successful they are in filling their vacancies and measuring the turnover. There's a behavioral health module that now includes peer counselors, which I think is an important part of that, and also a dental module that looks at recruitment and retention strategies for dentists. So this is some more, I think, exciting work going on in number 5 and workforce. Now, next slide, number 6. Oh, no, there's more. Sorry, I didn't make these slides. So there's a lot of workforce. We have a workforce unit. There's a lot of that. So there is Senate Bill 5167 for community behavioral health, had a funding reduction because of our budget impact at the state level. We also had a bill last session for certified peer support specialists, which changed the name of that instead of the peer workers that are there. And so we are working on developing some supplemental courses for peers related to domestic violence, sexual assault, and human trafficking, and also looking at ways to expand access to a peer support network. I think that work is moving. There was also a bill, Senate Bill 5118, around international medical graduates that removed a residency requirement and a few other sort of technical changes that were intended to remove barriers to international medical graduates being able to be licensed and be part of the workforce in Washington State. And then we also have some new provider resources from HCA's workforce unit that in the slides, it links to those websites for a recruitment and retention toolkit, and also a substance use disorder organizational development and assessment tool. Okay, now I think that's all. Maybe not. We're doing a lot in workforce. Yes. Okay, we can go back to the other one. Any comments, questions, changes to number 5 that we want to talk about? Okay, next, number 6. So number 6 is around the use of alternative payment models, and the committee endorses HCA's efforts to track and set targets for primary care expenditures using the Healthcare Payment Learning and Action Network APM framework categories, with the goal of increasing the percent of primary care expenditures paid through population-based or shared risk based payments, and that HCA will annually report expenditures by the APM category to any future primary care advisory committees. So then we can make recommendations about targets for that. Next slide. These are important because value-based payment is a range of payment strategies that are designed to contain costs while improving outcomes and improve quality. And that's typically accomplished through contracting between plans and providers. And these APMs tie payment for services to the quality of those services, or they create financial penalties or rewards for providers that might spend more or less, obviously, on those ends of the spectrum than anticipated. And there are a variety of ways to do this. Next slide. So our agency, we have an agency VBP measurement that happens that is underway, but not quite public yet. We also have the National Healthcare Payment Learning and Action Network survey. This now is not being led by the LAN. CMMI has decided to end their sponsorship of that. But the same survey has been taken up by AHIP and the Blue Cross Blue Shield Foundation. So there are expected to be national results as well that should be released in sort of the late fall, early winter. I will say that neither of them has primary care VBP reported separately this year. We had limited space in the agency measurement of VBP, and last year's results showed that most of the category 3 and 4, so the more advanced models, were almost all primary care providers. So I think VBP is alive and well for primary care. And I think we will have to keep tabs on that because in this rougher economic environment, I think some folks are less interested in pursuing these types of payment models. So we'll have to keep tabs on that. Are there any comments, questions, changes? Okay, next slide. Last one, number 7. Number 7's around our measurement strategy, and the committee endorses HCA efforts to measure expenditures on a per member per month kind of basis or a per capita basis, and start thinking about that. I will say that that's one of the things that the OIC measurement effort is going to do so that the volume of people doesn't impact primary care spend in sort of a way that's unexpected. So I think, oh, but I jumped into my last slide. So next slide, why this is important. So when we established our primary care expenditures of 12%, the legislature relied on the experience of other states, including Rhode Island and Oregon. And that 12% expenditure target will drive investment in primary care. But particularly Rhode Island has started to have conversations that this may not be the best target to use indefinitely because changes in expenditures to other service categories might dictate the level of primary care investment, and there might be fluctuations that aren't really, I guess, attributed to more primary care spending. And so we wouldn't want our target to be sort of unduly influenced by changes in price and utilization of other services. Next slide. So I said there's no efforts currently underway, but when Nico was speaking, I remembered that we have talked about doing that for the OIC ones. And so I think this is sort of a little bit underway and TBD. Are there questions or comments about that? Anything else to say from others on the call? Okay, excellent. Next slide. So this is a summary of what we recommended last year. So 2 new policy recommendations of increasing primary care expenditures and increasing Medicaid reimbursement, and then 5 endorsements of activities that were already underway. And so this year we need to decide if we are keeping all 7 of these, keeping the language the same, doing any other changes. So I'm gonna pause here and we need to discuss any changes that have to be made, and then we need to vote. So I'll pause here and see. I think the two places from the summary that I think we may need to have more discussion about is, should the increased primary care expenditures be 1% or 2% for this coming year? And then we are not going to get to Medicaid reimbursement to Medicare levels by 2026. And so if there are changes that we want to make to that in some way, or if you guys want to say, yes, we are sticking to our strategies, that is also totally fair for you guys to do. So I'm going to stop talking now.
Well, Judy, I would recommend on the first one to change our percentage to 1% to align with the cost board. So I don't know how we do this. Is it a motion or?
It is probably a motion. Yeah.
Okay, I'll make the motion.
Okay. Is there any discussion? We talked about it a little bit under recommendation number 1. Are there other things that people want to add into this? Okay, then I'll have, Katina.
Hey, Judy. This is Katina. I guess I would tend to lean towards the 2%. We really want to get to that 12%. And that's reducing it half of our goal of 2% down to 1%. So I would urge us to think about kind of our overall goal, and it's probably not realistic to really get that 2% every year, but I think trying to be somewhat aspirational is a good thing. So my 2 cents. Thanks.
Thanks. Anyone else? Jonathan?
Hi, yeah. Just regarding the primary care expenditures, I think the first go around I was in support of 1%, and I just wanted to reiterate my support for 1%. I recognize that in the estimates provided today, we only receive sort of claims-based expenditures and not claims plus non-claims. But in that, we're looking at something like 3-ish% expenditures on primary care. And an increase in 1 year by 2% would be increasing primary care expenditures by essentially like 67% over the course of 1 year. And just thinking about what proposals might be entertained, I feel like 1% might be thought of more critically, more seriously. Hence my support for 1% for our recommendation. As a second note, one thing that I was wondering if you or other members of the staff could shed light on is the upcoming, One Big Beautiful Bill Act, which the Kaiser Family Foundation estimates that Washington might be the hardest hit state of any state in the United States when it comes to enrollment and spending cuts. My concern is, in addition to enrollment reductions, is whether primary care reimbursement rates or reimbursement rates writ large are at threat with upcoming provisions coming to fruition. And so my question for you is, that concern well warranted? And if so, going to number 2, increase Medicaid reimbursement. I think that my framework maybe changes of, if we're not in an environment where we can increase Medicaid reimbursement, if language needs to be framed of like protecting primary care reimbursement rates from any rate reductions if other elements of care anticipate rate reductions.
Thanks, Jonathan. And yes, I agree. We are in difficult economic times, and it is expected that over the course of the next couple of years that a lot of people will lose Medicaid as insurance, and the subsidies on the exchange are going away. And so people are likely not to be able to afford coverage there, which will increase our uninsured rates, and I think add more stress to the system all around. So I think that is a warranted concern. We are trying very hard to figure out how the work requirements will work. We haven't gotten any information about that from CMS, but trying to sort of get prepared and see how we can protect folks, and if they're eligible, be able to keep them on Medicaid. But I do think we're in for a rough couple of years. So yeah, I like your second one. But we have a motion on the table for number 1. So are there any other comments about 2 or 1? Then I'll ask that you raise your hand to vote to your yes vote means that you will have we will change the recommendation from 2% to 1% increase in primary care spend per year. And so if you agree with that change, please raise your hand. And staff on the phone, I think I have 6, is that right? I want some help in double counting.
It looks like 7.
7, okay, 7, excellent. And then please lower your hand, everyone. And then people who vote nay, which is to keep the recommendation at 2% increase per year, please raise your hand.
I see 3 hands.
I see 3 hands. Okay, thanks. So this recommendation will be changed to 1%. Next, let's take on 2 about increasing to Medicare rates. And Jonathan gave a proposal about at least maintaining Medicare rates or not cutting them further. Do people want to wordsmith that or have comments about that? Let's have a little discussion.
I agree with Jonathan's point regarding protecting primary care rates. If you think, I don't know if you have any insight, Judy, where things are going to go, if you think that there is a risk that they could reduce them. And if you think that that's a possible real risk, then I think that's probably the direction we should go, because obviously the increase isn't going to come that we want.
Yeah, I think it is a risk. And yeah, the legislature is in the governor's office is, as they do during downturns, asking for the list of what services are optional and starting the conversation now. So I think there could be a risk, and I actually really like changing this to protecting primary care rates. Yeah, Jonathan, did you have anything to add? Your hand went up and then off.
Yeah, I figured if I was going to self-critique my suggestion, and then sort of share where I land, which is the protecting language, or maybe a yes and situation, is I think moving towards protecting language moves our stance away from aspiration for primary care. And I think sort of the purpose of this committee is to be an aspirational force to move primary care forward. And I think moving towards protective language can be a little bit self-defeating. Having said that, the way I understand our recommendations for this year is that they're recommendations for this year. And I think, economic circumstances are such that perhaps the most aspirational thing we can do over the next 12 months is self-protection. And so in my mind, I would like to either keep the aspirational recommendation, and also say must not reduce rates in light of blah blah blah. But if we're sort of deciding to pick a lane that's we feel would be most realistically heard and adhered to, I would err on the side of the protective language, which is why I made my original recommendation.
Great, thanks. Maddie?
Yeah, I agree, Jonathan, with what you're saying, but I would rather leave it what the aspirational, let's increase the Medicaid reimbursements, but at the same time, just add a little addendum to it saying, and not allow them to be decreased from the current level.
Like that, Maddie, maybe the language is around maintain, right?
Right.
Maintain current,
Right.
something like that.
Yes, yes.
So I'm going to throw out some words, and maybe staff, if you can write these down as an attempt at this, that our recommendation would be the legislature should maintain current Medicaid reimbursement for primary care services, period. Ideally, Medicaid reimbursement should be raised to Medicare rates. I don't know, something like at the soonest opportunity possible, or something like that. Or maybe not the ideally, but that maybe it's just that Medicaid reimbursement for primary care services should increase to Medicare rates as soon as possible. I think, is that what I said? We need some on time editing. What do people think of that straw person?
Let me read back what I tried to capture. I might have missed something.
Yeah.
Should maintain current Medicaid reimbursement rates. Ideally, Medicaid reimbursement should be raised to Medicare rates at the soonest possible opportunity. And then I don't have language regarding the maintain. So if you guys have suggestions for us to capture on that.
No reductions. Did you hear that? Maybe say no reductions in Medicaid reimbursement.
Okay, ensure no reductions.
Maybe the third bullet here could be changed to the payment rate for any services, for any primary care services, should not be changed.
Sorry, Judy, can you say that one more time?
Yeah, so I'm looking at the third green bullet on this slide, and I think we could maybe change it to the payment rate for any primary care services should not be changed. So taking out the enhanced fee schedules and taking out the at or above, because I think it's really all primary care services that you don't want to be changed.
Okay, so updating it to reflect the payment rate for any primary care services should not be changed, and then just omitting the rest of that sentence.
Yes.
Okay,
Or
perfect.
what, can we say should not be reduced?
Yeah, because
Oh, should not be reduced. Yes, you're right.
Not be. Good catch. Thank you.
Good catch.
Okay. Should not be reduced.
And
So
then
that
we
would
take
read
out
payment
bullets
rate for
2
any
and 4.
primary care services. Primary care rate services should not be reduced.
Yes.
So I guess Judy, if you want to take a vote just to make sure everyone's in agreement with that updated language.
Okay, and we would delete on this slide bullets 2 and 4 with that language.
Delete 2 and 4.
So does anyone have a motion for our new language here?
Motion to approve the language just discussed.
Excellent. I'm not sure I could say it again either. I will have folks raise their hand if they are aye to approve this new recommendation.
Okay, it looks like 8 hands.
8 hands. Yes.
8, 1. I didn't go to the next page.
Okay. 8 hands, 9 hands.
Yes, 9.
9 hands. Great. Please put your hands down. And then are there any nays? Okay.
I'm not seeing any hands
This
for that.
changed recommendation passes. Shannon, do you have a question or a comment? Hope you're on mute.
Sorry, I was trying to say that I accidentally clicked chat instead of hand. I meant to vote yes for that.
Okay.
Sorry.
Okay. Thank you.
I was going to
Okay.
point out, I think we're missing one person because the last vote we had 10 and I only counted 9 hands. So thank you.
That was me with checking the wrong thing.
Okay. 10 hands.
Thank you. And then I think the last 5 that are support, maybe we can move to that second to the last slide that shows all of them again. Yes. Shall we continue to endorse these last 5 strategies? And Shannon? Oh, your hand was still up. Okay, thanks. Crystal?
I'm just reflecting on the, what Jonathan brought up, just the environment we're in, right? Where it's so tricky to move some of this forward. And what I think of from a provider perspective is going to be the most important thing in the next several years, it's keeping our patients covered. And we talk about patient engagement, and that's just going to be the most important thing. And it wasn't on our, wish list from last year because obviously the environment's changed. And I know we don't have a lot of time to brainstorm maybe what that looks like, but I would recommend we somehow change our endorsements to just prioritize that. And I'm not sure exactly what that looks like, if it's, a statewide effort or communication plan with patients, if it's, I don't have a specific strategy, but just making sure the board recognizes that for some of us is going to be the top priority.
Yes. I think that that makes a lot of sense. I wonder, we could move patient engagement to number 3 and swap it in position place with multi-payer alignment. And then we could change, I guess the making care primary part has to come out anyway, but that we endorse, so that it would read, we endorse any state agency efforts to support incentives for members to access primary care services. And then we could add a bullet that would say something like any state efforts to I don't know, maintain insurance coverage or help patients find insurance or something like that.
Yeah, and then I don't know the feasibility, but in addition to that, whatever we can do from a inner data perspective for eligibility, however we can make, I think the state has some impact in administrative efficiencies around insurance enrollment for Marketplace and Medicaid for sure,
Okay. Yeah, that makes sense. Jonathan?
Similarly, in the context of unknowns for the future, if reductions in funding for Washington Medicaid brings the possibility of patient level cost sharing to the conversation, I see the potential value in adding language to our patient engagement strategy to protect primary care services from patient facing cost sharing.
Oh, I like that too. Yeah. So to add maybe a bullet under patient engagement that that recommends no cost sharing for primary care services.
Yes.
Okay, so just to make sure I'm following correctly, Judy, on what the Primary Care Advisory Committee's recommendations are, move patient engagement up to number 3, and then also add recommends no cost share for primary care services.
That is part of the patient engagement one. Or is that a new one? I don't know. It could be either. I think let's put it under patient engagement, those changes.
Okay. That was what I was doing. I just want to make sure that you guys agree with the way that I'm capturing this.
And I recognize we're running out of time, so I might ask for a motion to continue to endorse these 5 efforts with the changes made to patient engagement.
Judy, I do think this meeting is scheduled until 4:30, just so you do have a little bit more time to get through the language if you need to, just to let you know.
I only have it till 4 on my calendar. Do others have it until 4:30?
Drop it. Jesse, drop it.
Or do people?
No, mine's till 4.
Yeah, 4.
Yeah, I think it's till 4. So
I'll make a motion, Judy.
okay, thanks.
And I'll second it.
Excellent. So please raise your hand if you say aye to doing those things we just talked about.
Okay, perfect. It looks like I see 10 hands.
I think that's everyone that's a yes.
Yeah, perfect.
Okay, so no nays, and we will circulate this final language with you guys by email just to make sure we got it right, and if there's any tweaks or things there that we might want to change for the board. Next slide, and actually the slide after that, I think. The slide after that. Thank you for joining us. Next steps are This brings us to the end of today's meeting. We are going to plan to meet around the same time next year in August to review the primary care data, the current efforts, and make any updated recommendations to the cost board. Although we only have one regularly scheduled meeting in 2026, I do want to say that there could be other things that change. As we talked about today, we are in a very dynamic environment. So we may need to have an additional meeting, and then I will bring that to you. And then if we do any more additional meetings, we'll keep you posted. Emails will come out of the HCCTB inbox, so you can keep an eye out for that. Please let us know if you have contact changes. There have been a number of folks that have either moved or retired, and so we'll also try and find some new folks to add on to this list. And the cost board is meeting again on October 23rd from 2 to 5. And that is when I'll be presenting our recommendations to them during that meeting. And so I want to thank our presenters again and thank all of you committee members. We for sure have a lot of work to do together, and this is, buckle up. These are some crazy times. I look forward to continuing to meet with you. And I also want to wish Katina a happy birthday because apparently we scheduled this on her birthday. So thank you all and take care.
Thanks, Judy. Happy birthday.
Yes. Birthdays
so
are fun to
much.
celebrate.
Thank you.
Thank
Thank
you.
you.
Thanks.
Thanks,
Bye.
everybody.